actually
The
three
Bogus
components. So this will be the
Spin
first
Report.
of three. So thank you. Hi, sorry for the delay in getting back to you on the Bogus Spin Report, but we've had a little bit of excitement in the Middle East, and that's kind of taken a lot of the attention away from some of the major issues that our Congress should be looking at. And the major one happens to be the Prescription Drug Pricing Reduction Act. One was passed in the House, another is going forward in the Senate. They're different significantly. The big part, and it's one that is a major issue and has been for a long, long time, is that the Medicare, which is a major purchaser of drugs for all of the people who are A, disabled, or B, older and on Social Security, they never negotiate drug prices. And as a result, the drugs are sold to that system at list price. Now, the House bill plans on doing something about that, whereas the Senate bill does not. They say, both bills say that they'll look at a number of drugs and make sure they don't go up above, inflations, but that's where it is currently, or would be, and that would hold down drug prices from where they are right now. But right now, for example, insulin costs 10 times as much in this country than it does in other countries. So, we have a long way to go, and that's why the House version has some legs. I think that the Senate version does not. Now, the only problem with either one of those is that it does nothing to reduce drug costs for many people, because many people, they have to pay a copay on their insurance, whether it's commercial or if it's a drug company supplying Medicare, they pay based on a list price. So, for example, if you have a drug that costs $1,000, you'll pay, say, 10% of that, and that will be $100. However, if they reduce the price because they negotiated, whoever it might be, to $500, you would think that you would only pay $50, not $100, because the price is half as much. But that's the negotiated price, and the drug companies frequently and Medicare charge based on the list price. So you can reduce the price all you want, but it has no impact on you whatsoever. So the only thing in both of them that have value to the people who want to have life-saving drugs is when they limit the amount of total copay. Right now, you can pay, for example, in Medicare, you can pay as much as, depending on your drug costs, as much as $20 or $30, $40,000 for your drugs because of the way that it's structured. With private insurance, it could be even worse because some of those are even higher. So if you set the maximum at $2,000, like the House version says, or I think it's $3,100 for the Senate program, that's the end, or it stops. Now, the only issue with that happens to be that the House version doesn't allow you to spread that cost over the entire year. The Senate version, I think, is supposed to do that. But the importance of that is that if anybody goes to, according to some studies recently, anybody going to have a prescription filled, if they see that their copay is as much as $2,000, 50% of the people will abandon it at the pharmacy. So what that means is that many, many people don't use the drugs that they're prescribed. And as a result, if you have cancer or heart disease or anything like that, that requires very expensive drugs, that, well, you're just out of luck. So I think there's really three parts that need to be addressed, and and I call it bogus spin, because you're really not getting the truth. You're not getting what's actually happening. The first of which is reducing negotiated prices will improve affordable access to life-saving drugs, and I mentioned that a little bit so far, but I'll expound on that. The next is that new drug innovation will be stifled if somehow Medicare negotiates price, and that's kind of that's another segment that I'll talk about in the future, but it's just bogus spin, or like my report in shorthand says, it's BS. So the last thing is that we say that we have the best medical system in the country, and that it's the best that money can buy. And the caveat, if you want to call it that, it is that if you do in fact have great insurance, if you have good coverage with secondary insurance as well to pick up excess drug costs, or if you have hundreds of thousands of dollars to spend, or millions for that matter, then yeah, it probably is. But we'll talk about those things in the future. So reducing prices. Most, like I've said before, the copay is based on the negotiated price. But in addition, as the cost of the drug goes up, most copays, for example, will provide you with prescription drugs at a very low copay, $5, $10. But as the price of the drug, or the fact that it happens to be a very expensive drug, which is which has still is covered by a patent, that drug will have a much higher copay. So it'll go from $5 to $15 to 20 to 35% or greater of the cost of the drug, which could be many thousands and perhaps hundreds of thousands of dollars. They call this pricing system the tier system. It's spelled TIER, and specialty drugs is at the top of the tier system, and that's the one that's usually patented, like for cancer drugs or other things like that. And what you'll find is that, for example, I have cancer. I have multiple myeloma. It's a incurable cancer of the blood, and it requires, and now I'm on Medicare. So if you look at my situation, or any Medicare patient for that, it's just not mine. I happen to be pretty good. My wife was working in the healthcare system, not in the healthcare system, but with autistic kids at schools, and she was an assistant at the school, and she had union benefits, and those benefits were with Blue Cross and Blue Shield, and they were excellent. And in addition, and it's odd to say, I fortunately had dialysis-dependent kidney failure because of my myeloma, and because of that, I could get Medicare as a secondary very quickly. And that allowed me to pick up those 20% copays. And so, 20% copay on a $500,000 stem cell transplant, where they, kill all your bone marrow and then put your own stem cells back in to repopulate your bone marrow. That $500,000, 20% of that is kind of a big ticket. So, a lung transplant or a heart transplant or things like that, or open heart surgery. Most of those are way up there as well. So if you have if you have Medicare, in order to get those things covered, like the high copays of A and B, you need you need to get Medicare, which is $135 a month for A and B. You need to get like I think it's a G or an F plan, and either one of those cover most of the copays. And those plans cost about $4,000 a year. And then the drug plan, which is $70 or so, which is another, close to $1,000. So you end up paying about $5,000 just for those. And that'll cover most of that stuff. But you have one drug with myeloma, and that drug is Revlimid, which is a major drug. Your copay is $14,000. And so if you take $14,000 plus 5, it's $19,000. The average person on Medicare averages $26,500 according to it's a group. The Kaiser Family Foundation says that it's $26,200, and that was in 2016. And so if you take 3 years at 1 or 2%, which would be the factor that increases it, that's about what it would be today. So with $26,200, just one drug, which would get you to $19,000. It's tough to live on $7,000 a year for housing and all that stuff. And for me, I think, and for many people, you would consider that senior genocide, and that is unfair. And not only that, for people who don't have insurance or have normal, insurance with their companies, they will be confronted with the same issues. However, they don't have limits to the amount that you might have to pay, or in some cases they do. So if you look at the size of the problem that we have, it's that 600,000 people die of cancer each year. And even more than that die of heart disease, because that's the number one killer. So it's well over 1.2 million that die from this thing. And if you look at our Civil War, which is was the largest single loss of life of the military for any war for the United States, that was 600,000 people over 4 years. So you can see this is a huge, huge issue. And so some things that need to be done in regard to this is that maybe the copay should be limited to $150 per month or something like that. Take 2,000 divided by 12. It shouldn't be $3,200, because if you add that on top of some of these already expenses that you got, it's still a big number for the people who are least able to pay for it. So with those types of things, for our country, which spends twice as much on healthcare than any other country in the world, to think that on any measure, like on life expectancy, death from childbirth, all that stuff, on any of those measures, seldom are we ever in the top 10. So we pay twice as much for, a system that's not even in the top 10 in the world. Just makes no sense to me whatsoever. So, if you look at it, it seems to me that this is not a great deal for this company. As a matter of fact, this might be, the art of the no deal. So with that, I'll be talking about some other things in the near future. For example, the drugs, how they are developed, and where the innovation comes from, and also why just increasing one element of the supply chain cost is not going to be that significant. And it's been said that in a number of studies so far. So that is truly a terrible bogus spin. But what we'd like to do is just to get the access that we deserve, given how unbelievable the costs are associated with our healthcare system. So with that, thank you for listening to me. I hope I didn't bore you too much, and hopefully our senators will get off their duff and finally do something to the benefit of those who are ill and those who expect their insurance to cover their expenses. So thanks. You take care. Bye-bye.